You similarly might have a SMART goal, hypothesis, objective out there, but here you have a more dynamic methodology where you're doing this trial and error, and the outcome is by whatever means necessary to meet that final objective, regardless of how many permutations you have to make. So that's how I think about the big difference between research and quality improvement. Both are difficult in their own right. Today, the residents are going to be talking about one of their QI projects, acute inpatient rehabilitation send-out reduction through evidence-based protocols. And they will be stepping you through really how they came about with this topic and where they are in that process and the things that they need to do going forward. So we'll have Trevor speaking next as the QI lead.
Hey, everybody. We have no relevant disclosures. So just to kind of set the stage for what we're going to be talking about this time, this is an example of send out numbers, send out data that we had on two services that here in Sheltering Arms are both, stroke services, and in theory they should be essentially the same in terms of the patient population and the patient acuity, the things that we would need to deal with medically after the patients get here. However, looking back at these two services, we saw a major disparity in the the number of patients that were sent out, and then the number of patients that were returned within a short enough time frame to Sheltering Arms, such that they were on the same admission, not being sent out and then having to come back on a new admission. One service had a 38% return rate versus a 54% return rate for the other service. So why did we have such a big disparity is something that we were curious about. To further set the stage, in June of 2023, send out trips became much more expensive, nearly doubling in price, both for non-emergency and emergency critical care send outs. And one thing we wondered is who would have to pay those costs, and we found that it was dependent. The major question being, did the patient return to the acute rehab facility within a certain period of time that was pretty much decided on by insurance companies or Medicare? If the patient did not return within a certain period of time, such, for example, if they were admitted to the acute care hospital, the insurance company or Medicare would have to be on the hook for that cost. If the patient did return within the 72 hours or by midnight on the third day, as some insurances require, in the inpatient facility, Sheltering Arms being our example that we studied, will be on the hook for the whole bill of all the services and workup done at the emergency room or acute care. And furthermore, in acute rehab facilities that are freestanding hospitals, such as we are at Sheltering Arms, the cost of the transportation back and forth would also be kind of eaten by the acute rehab facility itself. Of course, we ultimately care most about the effect that all of this has on the patient. One thing that we find is that the total duration of their time in the hospital is extended when they're sent out. In cases where maybe they don't need to be sent out, their total duration could have been shorter. We also find that bed availability at rehab and insurance authorization for coming back are problems. If they are admitted to the acute care facility for too long and they have to be, they have to reapply and get new authorization for inpatient rehab. This also extends the time as well. And then while they're, sitting in the acute rehab or in the acute care hospital, waiting for authorization or waiting to return to rehab, they're also experiencing some functional decline as well because rehab services and overall activity level will be significantly decreased in the acute care hospital compared to in the acute rehab hospital. And then also, we always worry about the number of kind of hands that are, in the pot, trying to take care of the patient. The more people that you kind of involve in the care, the more opportunity there is to kind of drop vital information and cause medical errors. We all remember the Swiss cheese model from our medical education. So send-outs have an impact on multiple different key stakeholders. We find, as we talked about, benefits to the patients of being sent out. Sometimes we just decide better safe than sorry. There's less risk for them to get more unstable, and they get, more comprehensive medical management in the emergency setting. However, as we discussed, they also have the risk of further functional decline. Their total hospital stay is extended, and the increased risk of errors in medical handoff. The hospital, the acute stay hospital themselves also have some benefits and risk. But here in Sheltering Arms, we care about the benefit and risk of the, to us as a freestanding rehab hospital. We care about the risks of higher transportation costs that we would have to eat if the patient doesn't come, if the patient comes back, within a shorter period of time. All of the acute care costs that go along with that workup and management. And then just readmission rates as well. So this is some data from fiscal year 2022, reasons for send out. Of all the reasons for send out, we found that cardiac and sepsis and altered mental status were the major, the top 3 reasons. You'll notice that in blue we have the fractions of those send outs that were returned within that, that short 72-hour window, in which case the inpatient rehab facility would have to eat the cost of that send out. So we wondered, is there, why are we sending all these patients out? Is there a fraction of them that this fraction of them that comes back within the 72 hours? Is there a way to prevent, having to send so many of them out? Can we keep them in house and treat them here instead, and kind of save that the adverse effects of that send out situation? We decided to study sepsis and cardiac, as those were 2 of the top 3 reasons for send out, and we had the most data on those, but we are continuing to study additional reasons for send out as well.
So in regards to our project methodology for this QI project, our initial SMART goal was to reduce the amount of acute care send-outs in total by 10%, and the within stay readmissions, or the readmissions within back to IPR from acute care within this kind of the 72-hour window, reduce that by 20%. We wanted to have that done by July 2024. This is a summary, very obviously succinct, compared to the amount of work that went into making sure this got off the ground, involved case review of looking at specific patient cases, both here and in acute care. Looking at the current state of what we did here at SAI in regards to send outs for both cardiac and sepsis. Getting expert opinion / literature review. Big part was staff buy-in, and resource allocation from both leadership and nursing and therapists from here at SAI. Standardization of the processes, making the actual protocols and implementing it. And then some trial and error with some education, monitoring, revision, to try and figure out the best way to go forward. In regards to our measures of interest, our primary one was number of send outs per month, per the average census. Also reason for send out and eventual diagnosis at acute care. Both of those were determined by chart review of both SAI and acute care patient charts. And then the percent of returns within back to SAI from acute care within the same rehab stay.
Okay, so I'm gonna chat about kind of our humble beginnings of the program, where we sort of started in the process. And then dive into a little bit of the research that we used to come up with our final protocols that are now live for both sepsis and chest pain. It's not a QI lecture without a fishbone. So start at the head. The problem was sending out for sepsis, and we sort of brainstormed in a few different lecture series about all the various underlying causes. But I think some of the biggest ones that we had seen when we compared ourselves to some community hospital systems was having specific order sets and specific criteria to help basically stratify the patients was something that we were lacking in. And so that was sort of where we focused pretty heavily for both of these protocols. And then diving into the literature, particularly for sepsis, CMS has basically created their bundle of what they consider for quality outcome measures for sepsis, including things like getting a lactate, getting a blood culture, starting broad spectrum antibiotics and fluids, and then repeating a lactate again in 6 hours. There's a full essentially checklist of items to accomplish based on their quality outcome measures. And the reason that we're sort of following that in terms of the basis for our protocol is moving forward, looking through like value-based purchasing programs and essentially reimbursement figures is all going to come through following of this SEP1 bundle. So that's kind of how the backbone, that's where the backbone of our protocol came from. And then, and more specific to Shelter in Arms and VCU itself, some of the pharmacy team and infectious disease docs downtown had created essentially an antibiogram that most people are familiar with, but if you're not, specifics to individual exposures that patients may have within VCU system itself. And so that's another part that we had pulled from when we look closer into the diagrams or the protocols of why are we choosing certain antibiotics to start empirically. There's also a micro guide that we're using for some of the other protocols in the pipeline, looking at different sources, looking at things like bloodstream infection versus if we think it's skin and soft tissue to help us guide, again, being more specific to VCU system in and of itself. And then, of course, utilizing the Surviving Sepsis campaign to kind of bring all these pieces together.
And I'll touch on the specifics of the order sets that were implemented to put these protocols into place. And this was done with bi-weekly meetings with the physician leadership here, as well as the IT team that composed of some of the Cerner experts that were able to build these sets, and then a project manager from Oracle as well. And for the Cerner order set for sepsis, this will start at the top of it. So for the next slide, it's the same order set. And for each of these, we had chosen to put the recommendations for an immediate send out for a reminder to the providers that was readily available within Cerner. And for sepsis in particular, we're added in the specific vital sign targets that we chose for this that were based on other institutions and previous literature. In particular, we paid close attention to the respiratory status of a patient, since that would cue us into indications for an earlier send out. And then recommendations for a potential delayed send out here, where maybe we were trying to implement these things but would consider it later, would be, for instance, the inability to place an IV in 30 minutes, and that's just looking at the delay in the patient then receiving antibiotics and fluids. And then just considering, you know, the patient-centered care of when we're notifying family of a potential send out, if they have preferences for their family member to be sent out early, then making sure that we're taking that into consideration as well. We also added a reminder at the top for providers to also add in the sepsis into the iPass for physician handout to facilitate when shifts are changed, or if this is happening overnight, to make sure that there's another place where the primary team is notified. And then at the top of the order set, we have most of the monitoring and nursing labs that comes into play, and these are default checked so that they are going to go through. And what's nice is they kind of pull in some of our other order sets, and now they're just in one place. So making sure we're getting, you know, the IV flushes ordered for nursing, so that it's a complete order set. So physicians aren't having to go back to the computer to place those in later. And then getting our labs underway, so that helps facilitate when they're sent back over to VCU, which happens, you know, in the afternoon, during the daytime, or overnight. It gets all them done in one fell swoop. So making sure we're grabbing all of our cultures early, that lactate, and then towards the bottom, some of those labs that might not be relevant to every patient. So lipase remains unchecked by default. And then we also added in direct testing for some of the most prevalent respiratory pathogens as well, which is helpful since that's a more direct test that gets the most frequent ones, and then we don't have to go for the full respiratory panel by default, so this one is a lot cheaper. And then we also added in a default chest x-ray that's ordered stat, so that helps facilitate radiology to be notified of the urgency of this imaging being done. And if this were to be ordered, let's say overnight, when radiology isn't present in the building, then they would have that right away available, so they would know to prioritize this x-ray in the morning. And then we continue on order set to the antimicrobials. These are not checked by default, so this is up to the provider to decide which ones are indicated. We added in the vancomycin dosing by weight, so that's helpful, so that it's right there, easy to see, and we don't have to call pharmacy, so we can get that going. And then pharmacy, there's an extra order in there for pharmacy to help manage the vancomycin moving forward for the dosing and trough levels. And then next we have the fluids. So we did find that potentially in some cases we were underdosing fluids prior to initiation of this order set, so we added in the surviving sepsis recommendations of the 30 mils per kilogram, which amount to, if someone's kind of average body weight, that gets you almost up to that 2 liter recommendation, which is important for decision making later for escalating care. If someone were to be still hypotensive and you're concerned about their vital signs being unstable, that would be indications for starting pressors, and we certainly want to send out.
Okay, so now we're gonna kind of switch gears and chat about chest pain. Again, back to our humble beginnings. Dr. Highland graciously created this handout sheet workflow last year towards the end of his second year, which was the starting point for us, essentially, to say, you know, this is kind of our typical workflow when we do see chest pain here. But even in reviewing it, we had sort of noticed as a group that there really wasn't a consistent stepwise process that was followed here. And so back to literature we went, and you'll see some of these things highlighted in the order set. Excuse me, but starting with the heart score. is a very simple way for us to quickly stratify, is this patient at low, intermediate, or high risk for cardiac etiology? And you'll see it in I'm sort of stealing some of Dr. Moen's thunder, but you'll see one of the first parts of the chest pain protocol is to calculate the heart score. And if it's greater than 6, then we just send them straight to the ER. That puts them in a high risk category. So that was sort of one aspect that we had looked at. And the second part was looking through essentially the consensus statement from the American Heart Association and a number of other entities about essentially common guidelines for chest pain and how to work them up. And so this sort of was a starting point for us to build in our protocol a consistent workflow that is consistently used over and over again. So
Thanks, Troy. So, looking at our chest pain order set, pretty reasonable to say if they have a semi on the EKG that you just got, then send them out. But it's up there in case you wanted to double check that, I guess. I think most of us they'd be on their way. And then also just I think adding in broadening the differential on the top of our order set. So if we're concerned about P or aortic dissection, to also consider sending out. What's nice about the order set is it allows for the timing of the EKGs. So as things happen acutely, sometimes I think it's easy to forget to go kind of make a plan for rechecking a patient that we're concerned about. So we have defaulted to 2 EKGs, the first one happening and then the next one happening 60 minutes later, as well as consideration for an IV, and then medications to consider for folks with chest pain, kind of looking at the Monavash mnemonic, so kind of places to start for that. Chew aspirin right away, and then potential for nitroglycerin. That would happen obviously after the EKG comes back, to make sure that we're ruling out anything that would be dangerous before giving that, and then considerations for a beta blocker, statin, or morphine as well. And then the labs component of the order set for chest pain includes timed troponin. So the stat one would be sent right away to lab. And then we have one timed 3 hours later, as well as a CBC and BMP and MAG, just to make sure folks' electrolytes are normal. And then so we added the imaging here for the chest pain order set for chest x-ray here, and then oxygen therapy as well if that's needed to help facilitate that for nursing. Looking at areas for potential improvement after the chest pain protocol was implemented, one thing that came up was options for additional resources, especially overnight for reading more complex EKGs. Thinking about some of our patients that come in and they maybe had a CABG, they have a block where the EKGs get a little bit more difficult to read, and we don't always have a comparison. A lot of times we do try to get an in-house EKG here so that we'd at least have a baseline when folks have a more complex cardiac history. But not always, and we don't always have access to the acute care records. So one thing that the residents were bringing up was, hey, like, who's our resource, especially overnight, to run these EKGs by? So Dr. Carter graciously talked to the cardiology fellowship director at VCU, and they okayed us to go ahead and talk to the KQ fellow overnight, which is kind of the impetus for that is that on the floor, if we have patients with complex cardiac histories, in the VCU acute care side, the KQ fellow is a resource for residents overnight with questions or concerns. So we did get that okay, but then when it was implemented, I think what happened was there's just kind of a lapse in that it wasn't maybe communicated with the fellows or whatnot. So the fellows kind of were unaware, so that didn't end up to be a resource that we were able to utilize as much as we thought. All right, so now we'll move on to some of our data that we've collected and then conclusions.
Yeah, let's talk about our numbers now. Starting with the chest pain data that you can see here. So this is a breakdown of our pre-protocol chest pain data. Our sample size was 40 total chest pain sendouts, and only 3 of them, 8%, and then actually being heart attack, which is obviously the big diagnosis we're trying to catch when we're talking about chest pain. 60%, 24 patients, had some sort of abnormality on their EKG, but only 8% of these patients even have like an elevated troponin here at SI. 75% of the patients had a heart score greater than 4. And originally, we wanted like heart score to be like a bigger part of the protocol. But because of our patient population here at SAI, like with their age and comorbidities, a lot of patients just like naturally have like a high heart score, as you can see here. And also because there's like sometimes a delayed getting back like the troponin here, the heart score just really didn't end up being too helpful, unfortunately. Of the patients in Optum SAI, 77% of them eventually returned to sheltering arms, 20% ended up going to SNF, and 3% actually went directly home from acute care. But most importantly, 65% of these chest pain patients returned to sheltering arms within that 72-hour window, which kind of creates like a bit more of a financial burden on the healthcare system, and then also obviously for SAI. And probably this wasn't also the best thing for the patients either, potentially. Our chart review showed that only 55% of patients actually even had like any change in their management by acute care either. Once again, demonstrating that could have been managed here at sheltering arms. And as far as diagnoses, 55% of these patients did not even receive a formal diagnosis. 13% were diagnosed with either heart strain or MI, heart attack. 10% actually ended up having a PE, and then 5% were diagnosed with arrhythmia. So had we used our new send-out protocols, kind of including like all this in kind of talking about if the EKG says STEMI, not a send-out, it considered a PE or air dissection, consider send-out, et cetera, only 11 of these 40 patients would have actually met criteria for immediate send-outs. And the other like 29 of them we probably could have managed here pretty well. And then here is our preliminary data, kind of comparing 2023 to Q1 of 2024 by the time that we had like these protocols up and running pretty well. So in 2023, there were 51 total cardiac patients, or 51% of the 51 total cardiac patients returned to SAI within 72 hours. And then so far in 2024 Q1, only 36% of our chest pain patients returned in that same window. So down about 15% so far with these new protocols in place. So it seems pretty good. And then in 2023, as far as sepsis, 9% of our 87 total sepsis sendouts returned within that 72-hour window. So it's pretty low. But so far in Q1 2024, 0%, literally no patients returned within 72 hours. And that was a sample size of 27 patients. So it's early, and the numbers, especially from 2024, relatively small sample size. But the early results kind of indicate that it's a lower proportion of both chest pain and sepsis patients who are returning within 72 hours. And we can kind of take this to mean that our protocols are helping determine which patients can be safely managed here at SAI and which ones actually need to be seen in acute care and be managed there. So far so good. Maybe we earned ourselves a pizza party or something.
And in regards to future directions of what we're doing with these protocols, obviously right now we're kind of working on some more chest pain and sepsis protocol optimization as we, the initial data seems promising, but as we work through the kinks and things we may need to change, we'll continue to optimize those protocols. Other protocols that are currently in process, hopefully be implemented later. There's a hyperkalemia protocol, a loss of consciousness protocol, and then a protocol for altered mental status / suspected stroke. So exciting things in the future. These are our references, and thank you so much for attending. I'll get the rest of the QI squad up here for any questions anyone may have.
We thought James was just going to answer all the questions. But well.
So as you guys have put these into place, when you're here alone on the floor at night, do you find them helpful?
Yes.
Is it worth the work?
It was worth the work. Yeah, it takes a lot of guesswork out of what people should be started on and how and timing and things. It's nice to have it all kind of arranged. You can just kind of click some boxes and it just goes. It's convenient. Yeah.
Yeah, I would agree. I was yesterday morning, Tuesday morning, I was on call around like 6:30 a.m. Got like an alert, the patient met like sepsis criteria or source criteria, I went up and assessed the patient. And then I go back to like the resident room, like later, after seeing the patient. And then you just click like sepsis protocol, just click a couple buttons and then you're done, teed up. Mix that whole pathway really quick and simple, and you don't miss things. Like you don't like miss like talk about like DABI flush orders or pharmacy to dose vancomycin. It makes it like very simple and straightforward. Even like at the end of like a 24-hour call shift, I felt like it went very seamlessly.
And that was my patient.
Yep.
And that patient's doing well.
Nice. All right, there we go. A little bit of Vancomycin never hurt me.
I have.
So it sounds like the EKG thing never really worked out with the KQ fellow, or are we still in negotiations with them, or is it just forget about
I
it?
think part of that is,
For the fellows who graduate this year and then.
yeah, I think part of the challenge there is the logistics of it. So some people, particularly as second years, take a large chunk of the call. And roughly half of them did not do intern year here. So even just becoming familiar with the paging system
Yeah,
and how to look up who the KQ fellow is also another challenge. There's a specific web shortcut that's used on the VCU downtown computer systems that we don't have access to here. There is technically a way to find out who's on call by searching through Spoke.
Yeah.
But it is quite challenging if you're not familiar with the software. And so I think that's one logistic issue, and the other challenge is physically or electronically getting them the images of the EKG itself. I think doing that in a HIPAA compliant way is going to be markedly challenging for us, in lieu of snapping a photo and blocking out all the patient information and just sending the rhythm strip itself via, I don't know, text or something would be. That's the challenge.
technically, if it's VCU like managed,
Email, text on.
Or if you have Haiku on your phone and what if you take a picture through Haiku and then send it to KQ?
Yeah.
You'd have to have like their Epic Chat, or Doximity.
I think their KQ fellows have traditionally been the most responsive for the most urgent issues with their phone too. Like they have this internal phone that they carry too, so that might be part of it as well. I mean, I'm sure they're responsive to paging too, but we're like on their next tier of their typical ways that they communicate with
contacted.
the acute care teams.
So for now, we've been interpreting the EKGs.
Correct. Or the attending who's graciously on call with us at night will interpret or assist with that. Until AI takes over.
Yes. You guys talked a lot about the protocols. Can you go into more details about, first of all, what steps you think need to happen next for the sepsis and chest pain to make the numbers match up more so with the ideal we got from our retrospective review? I'll start with that question first.
Yeah, I think half the battle is informing staff that they exist and how to find them and when they're live. Which is something that I frankly was not aware that it was live as soon as it was. And so I think that's one thing, is just communicating that we do have the protocols in place, but then also having, our auxiliary staff nursing familiar with what's included in them, so that we know, okay, as soon as we fire it, that we're gonna have the materials that we need ready begin the process. I think that's a challenge that we see in any rapid that we have here, in any sort of acute setting, is that there's a sort of a short burst in the beginning of like, oh gosh, what's happening? What do we do? And so I think just being more consistent with it and knowing what it includes and what needs to be done.
Yeah, something that I think is like an overall challenge for the continued communication with clinical informatics in general, and I'm not sure that like the current leadership has a great solution at the VCU side. It's something that I floated by like Heather Masters of, hey, when you're implementing a new like kind of campaign QI for VCU, like kind of what's the typical communication that happens, and it's been via email, and then there's a you know, they've been sending updates from the chief clinical informatics officer, but I think with the Epic rollout on that side, it gets to be where there's fatigue of reading those. So it's like, you know, they kind of just get buried, and that's what has happened here. I know to myself of like, hey, it's been on my mind of like, how do I get updates from an institution that, you know, I'm not at as frequently now, right? And then my inbox here is like all the admissions stuff that gets clogged up. So it's like, how do you kind of filter that and then also stay up to date on the practices that are updated? And I haven't seen like a lot of great solutions necessarily for that. We have our SharePoint here, which is an awesome option where stuff can be compiled and kind of organized, but that I think gets lost to like when you actually go in there, right? Like what triggers you to go into our SharePoint to like look at it.
I think you can get lost in SharePoint pretty quickly.
Yeah, exactly. It's like I realized actually over the weekend, there's a ton of good resources in there. But I haven't explored them as much here because I didn't like have to as much, because I think when you're frequently kind of with your colleagues, like in the same workroom, it gets to be kind of like somebody finds out and then updates people. So kind of like word of mouth, like Troy was saying, but I think that's something that we'll have to work on as far as continued education for it. I think it's something that nursing leadership was starting to implement. When are they re-educating nurses about this, with especially the sepsis alert system? And it's come up, I think, multiple times for different things.
Anything else you do differently if you could go back in time?
I think part of the challenge in the beginning was clarifying our goals of the project. I think we had a pretty lofty ideal of a general consensus. Let's manage more here. It's kind of the initial thought that we had. So, okay, what does that practically look like? And even now, I think, you know, when we had first started, we maybe had 4 or 5 different potential ideas of protocols or problems to solve in terms of hyperkalemia or alternative status, you know, what have you. And so I think it would have been a little bit more efficient in maybe getting a protocol out sooner, is if we would have just said, okay, you know, for example, chest pain was our largest send out. So that's our biggest fish to fry. Let's fry it and finish that one and then move on to the next. I think maybe that would have been a little bit more, it would have streamlined the process a little bit. Until next year.
What do you think's the best next?
Probably the AMS, the altered mental status and falls or loss of consciousness one. It's probably next up.
Hyperkalemia is pretty well built and more straightforward than that one, so I think that'll get rolled out first.
Yeah, that one I just need to have my team build it.
Got it.
It's,
Yeah, AMS, I think it's a huge problem. Difficulty is it
Very
goes in so many different directions.
Yep.
Yeah. But
Hyper-K is, it could just flag itself
Yeah.
when you get the red number. If the red number is high enough, you just let go.
go.
Great job, you guys. It's really good undertaking by all of you. Thank you, Dr. Carter, for your leadership.
Yes.